HIV being a chronic manageable disease, I just wanted to put forward that there are many more other challenges as well when we deal with patients of HIV, which come forward whenever we have a patient of HIV. And so one has to be careful and always keep an out-of-box thought process so that we don't miss any of the other things as well, which we see along with HIV. Just to give a case as one of the examples, that this was a 39-year-old female with 3 kids, symptomatic since 1 month, presented to us with dry cough, malaise, multiple episodes of vomiting and abdominal pain, and loose stools with severe fatigue. Patient on inquiry was a known case of a retroviral disease, and she was diagnosed in 2013 while she developed tuberculosis pleural effusion. She was started on TLE regimen and anti-tuberculosis therapy. At that time, her CD4 was around 61. On follow-up, in around January 2016, her CD4 had dropped to 42. This was the time when her viral load was done, and it was found around 10,72,000, suggestive of failure, and so she was switched on to second-line therapy in the form of abacavir, atazanavir, and lamivudine. Patient was admitted at this time with these symptoms to a private hospital with high-grade fever and multiple complaints. She received around 7 blood transfusions in the ward stay, but because of financial reasons, she just couldn't carry forward much and presented to us at KM Hospital. When she came to us, she was extremely cachexic, she was pale, and had splenomegaly. On her labs, we saw that she had hemoglobin, which was low, and her total counts were also low. So she was basically bicytopenic. At this time, our differentials was whether she's harboring bone marrow tuberculosis or a MAC infection, whether we are dealing with some sort of lymphoma, drug-induced bicytopenia, or hypersplenism because of splenomegaly. So a further workup was done. Her USG showed that she had an altered liver texture, and there was splenomegaly. Just to remind you that her viral markers were negative, both hepatitis B and C. So a further workup of pancytopenia was sought, and a bone marrow aspiration with a biopsy was done along with cultures. Meanwhile, for symptomatic treatment, she was given blood transfusions. Her bone marrow aspiration report showed that her erythroid series were markedly suppressed. Myeloid series showed maturation, and there were 3% plasma cells. This was suggestive of a pure red cell aplasia. We all know, so as a result of this, we did send her parvovirus B19 PCR was sent. Meanwhile, an IVIG was started in the patient for management. The response was in the form of improvement in the TLC and hemoglobin. But the bone marrow biopsy now came, and this bone marrow biopsy showed a hypercellular marrow, showing trilineage hematopoiesis with megakaryocytes which were adequate, but there were increase in plasma cells noted. And it was reported as a reactive plasmacytosis. As a result of this, a serum protein electrophoresis was sent on this patient, which did show that she had hypergammaglobulinemia, and that was polyclonal, as you can see. Thus, our final diagnosis in this patient was pure red aplasia with polyclonal hypergammaglobulinemia in a patient with retroviral disease, which had primary ART failure and was on second-line therapy. Just to say that in HIV-positive patients, polyclonal hypergammaglobulinemia and other plasma cell disorders are quite commonly prevalent, both multiple myeloma and MGUS. The prevalence is around 2.5%, and there are increased risk of about 4.5% as compared to negative patients to develop multiple myeloma. What I would like to say with this presentation is that multiple myeloma in HIV negative patient is a common disease, but prevalence is more in HIV positive, and the presentation is a little earlier as compared to negative patients. The spectrum is wide in HIV patients. It could be one of the first presenting patient of an HIV, and heart is one of the indications. The other management of these polyclonal gammopathies are very similar to as any other patient of HIV negative. A take-home from this presentation would be plasma cell disorder is more common than in non-HIV. The diagnosis and management requires vigilance, and there could be 2 diagnoses as it was in our patient. So we should have an out-of-the-box thought process, and do not forget other diseases in HIV along with the same. Thank you very much.
Thank you, Edna.